Welcome, and thank you for joining us today. This is session 4 of the Pediatric Roundtable Series with the Lurie Children Center for Cancer and Blood Disorders. In this session, we'll be introducing you to Dr. Jennifer Reichek as she will discuss caring for the child survivor of cancer. My name is Chad Worley. I am your moderator today, and I am the Lurie Children's Physician Liaison for the City North and the North and Northwest suburbs. I'm joined by my colleagues, Paula Nowak and Julie Kalkbrenner. But before we move on to the discussion, I'd just like to tell you a little bit about the Lurie Children's Center for Cancer and Blood Disorders. We treat more children with cancer and blood disorders than any other hospital in Illinois. And although cancer is rare in children, we treat 220 new patients each year with a wide range of childhood cancers. We are ranked #1 in Illinois and in the top 10 in the nation by U.S. News and World Report. We see patients at our main hospital in the city, and then Arlington Heights, Central DuPage Hospital in Winfield, Lake Forest Hospital, and our Northwestern Medicine Proton Center in Warrenville, New Lenox, Northbrook, and Westchester. Dr. Jennifer Reichek is an attending physician for hematology, oncology, neuro-oncology, and stem cell transplant. And she's the director of our STAR program, Survivors Taking Action and Responsibility. And she's going to talk to you a little bit about that this afternoon in the presentation. She has clinical interests of solid tumors and adolescent oncology, long-term effects of pediatric cancer therapy, psychological impact of having cancer as child adolescent. And she sees patients at our main hospital downtown. And before I turn it over to Dr. Reichek, I just want to remind you that we are recording these sessions and we encourage engagement. So please ask questions as the program goes along. Type them in the Q&A section. Then after the session, we'll answer your questions. And if you would like to answer a live question, just please click on the raise your hand button. And if we can, we will answer your question live. Without further ado, Dr. Reichek, why don't you go ahead and please take the screen over. I'll stop sharing and go ahead with your presentation.
Great. Thank you so much, Chad. We will start from the beginning here. Well, thank you so much for this opportunity to talk about a population that is near and dear to my heart, and that is child survivors of cancer treatment. I'm delighted to be able to discuss this with you. And again, as Chad said, please put questions in the comment section because we'd love to answer all of your questions. Our objectives today are threefold. I'd like to help you recognize late effects that are associated with the treatment for cancer in childhood. We're going to talk about current standards of care regarding survivors of pediatric cancer, and there are, in fact, standards of care for survivorship care. And we're going to talk a little bit about the long-term follow-up guidelines created by the Children's Oncology Group and talk for a second about what the Children's Oncology Group is and why it's important that we have these guidelines for survivors of pediatric cancer. So let's start from the beginning. Who are long-term survivors of pediatric cancer? Well, I'm delighted to say that more than 80% of children who are diagnosed with cancer in 2023 will survive at least 5 years from their diagnosis. That means that at this point, about 1 in 250 adolescents or young adults are a survivor of pediatric cancer. Currently, there are about 600,000 survivors of pediatric cancer total living in the United States. And so that's a big, significant population of people here. And so why do we talk about late effects? You know, I think for most families with a diagnosis of cancer, although in the beginning we talk a little bit about long-term side effects of chemotherapeutic agents, until folks are finished with therapy, they don't really have the bandwidth to think about these things because the goal is cure for so long. And because we've gotten so good at curing people, we are starting to see people living into older adulthood. And so we really do care about late effects. So 90% of all of our pediatric cancer survivors will experience at least one long-term side effect, which is horrible when you think about it. You know, it's hard to tell families that we will cure their children of their cancer at a cost. And sometimes those side effects are minimal, but about 60% of our patients will experience a moderate to severe long-term side effect. And that may be a one-time issue, or that may be a lifelong condition that they will have to manage for the rest of their life. And so this is the reason that we start talking about it early and we talk about it often. So what is the definition of late effects? Well, a late effect is a sequelae of cancer treatment that's experienced at least 5 years from the time of a cancer diagnosis. It can occur in different aspects of life. It can be a physical late effect, it can be a psychological late effect, or it could be a psychosocial late effect. And so, we all in the medical field think about things like toxicity to the heart, toxicity to the kidneys, toxicity to the bones, neurocognitive issues. But there are certainly psychological long-term side effects. There's we all hear about post-traumatic stress disorder. What we found in many survivors of pediatric cancer is that there's also post-traumatic growth, so that although there may be some PTSD during therapy and shortly after therapy, that in the long run, what we see is that people come out of their therapy stronger as individuals. And psychosocially, you can imagine that education gets waylaid for a period of time and sometimes permanently, that a career trajectory can get interrupted depending on the time of the diagnosis, and maybe some of the long-term side effects. So imagine somebody who wanted to be an athlete who ends up with a brain tumor and has some mobility issues, that they'll have to change their career aspirations. There are many factors that influence late effects. The age that a patient is at the time of diagnosis of cancer, the tumor type and location, leukemia, lymphoma, or sarcoma. Every treatment is going to be a little bit different based on what the diagnosis is and where the cancer is located. And the chemotherapy, both how it's given and what is used. In addition, folks who get radiation are affected by both how much radiation they get and the places to where they get the radiation in terms of thinking about long-term side effects. And also surgery. I am primarily a solid tumor doctor, and so most of the patients that I take care of have a surgery at some point to take care of the bulk of their tumor. There are additional factors that affect late effects. There are physical complications that may be experienced during therapy. Those could be different types of infections or septic events. There may be wound infections. There may be all sorts of things that happen during therapy that end up with a long-term side effect physically. There's a lot of research out on the types of psychosocial long-term side effects of cancer therapy for children and adolescents. And we know that it's very important to make sure that people have psychosocial support during therapy. And that means both psychological, but also financial, meaning that they have a stable place to live, that they have food to eat, that they can make it to their appointments, and that they can afford the medications that we prescribe. And the coping style of both the child and their family. So, as we all know, taking care of a child is different from taking care of an adult, because you really have to incorporate that family system into all of the care. And so depending on how a family copes with things may influence the way that a child ultimately copes with a diagnosis and treatment for cancer. And current health-related behaviors. I wish I could say that survivors of cancer are more likely to be healthy and not drink or smoke or do crazy things, but in fact, just the opposite is true. They are likely to take more risks with their health, and I think that's at least in young adulthood, because of a feeling of invincibility, that they've survived their cancer diagnosis, and now why not jump out of airplanes or take drugs that we've said are bad for you or ride a motorcycle at breakneck speed. So we're going to talk a minute about the organ systems affected by cancer treatment, and I'm going to put them out there real quickly. So as we look at these things, we're going head to toe. And really, the gist of this is that late effects can essentially affect everything. Every part of your body can be targeted by some long-term side effect of chemotherapy, radiation therapy, and surgery. I'm going to talk about some of the big side effects. I don't have time to go into everything. You know, we could talk about long-term side effects and monitoring for long-term side effects and taking care of this population for a really long time. We don't have a really long time today, so I'm just going to hit some highlights. And again, feel free to ask questions. So let's start with cognitive late effects, because that's one thing that parents are always concerned about and seems a little bit unclear about how you diagnose them and who takes care of what and what you do about them. So the cognitive late effects that we often see in cancer survivors include short-term memory loss, decreased ability to concentrate and maintain attention, decreased processing speed, decreased ability to maintain organization, and changes in overall executive functioning. And a lot of times we don't see these long-term side effects when kids are younger, but we start to see them emerge during high school and potentially college when concepts become more abstract, when assignments are of longer duration, and folks are supposed to keep track of their own schedule and know when things are due. And so we really advocate in our long-term survivorship clinic that we screen at entrance to the clinic and then at transition points, or when either a child, their family, or their school system notices a change in something. So we always ask about how school is going, not only what your grades are, but do you feel like things are the same for you as they are for your peers, that understanding things are the same, that your ability to keep up with class are the same. And if that's not the case, then we advocate for a child and their family in two ways. We recommend neurocognitive screening, and we're lucky to have a team of neuropsychologists who will evaluate our patient population. We are also lucky that we have a school liaison who can work with school systems to start an IEP and make sure that kids are getting what they need to be able to be successful in school. When we talk about neurocognitive screening, there is, of course, as I just said, formal neurocognitive testing, but we also spend a lot of time listening to patient and parental report of how things are going, because we know that, first of all, formal neurocognitive testing takes hours and hours, and there's a long waiting list, unfortunately, because there are so many people who need help to advocate for their kids in the school system. So we really pay attention to what kids and parents say about how they're doing in school as sort of a quick and dirty assessment. We also engage the schools if there seem to be problems to see what the school thinks about how a child is doing in school, whether there have been changes, and what types of supports that child might need to be successful. Cardiac late effects is a topic near and dear to my heart because it's very clear, and we now understand the pathway through which some of our chemotherapeutic agents cause damage to the cardiac myocytes. We know the most common and the most famous long-term side effect of chemotherapy is a cardiotoxicity that leads to cardiomyopathy. We've learned a lot about the pathway for this and ways to combat it, but it does still happen. We also know that there's a significant amount of cardiac remodeling that happens in some people after receiving chemotherapy because of some of the toxicity to the heart. We also know that there may be changes in electrical conduction in the heart itself as a result of chemotherapeutic agents that we use. And all of these things may be seen during chemotherapy, after chemotherapy, and actually in the long term after chemotherapy. So as patients, get farther and farther out of therapy, even if they've had no cardiac side effects of their medications into adulthood, we recommend strict screening for cardiotoxicity because it can emerge as a very late effect. And we see people, adults with cardiac disease and metabolic syndrome, older than I would take care of them, but much younger than you would expect in the general population. So what do we do for screening? We use an echo, and the timing of echocardiograms for survivors is based on their therapeutic exposures, as is all screening for anything for survivors of pediatric cancer. We also use ECG to check the cardiac conduction, the electrical conduction. We also spend time talking with kids and their families, not just about their exercise tolerance, but encouraging them to get cardiovascular exercise for up to 30 minutes a day, at least several times a week, because we know that when people go through cancer therapy, they tend to be fairly sedentary during the therapy itself. And we want to encourage people to become more active, understanding that they are at a higher risk for heart failure and metabolic syndrome as they get older. Hormonal late effects are a big topic of conversation and has been recently in the press as well. We know that some of our chemotherapeutic agents cause premature ovarian insufficiency, or what's commonly referred to as early menopause, and that can start even in the teenage years. We know that it can cause primary amenorrhea, so some of our young women do not fully go into puberty without exogenous hormones. We know that young men can have low testosterone, and most of the young men go into puberty, but may not make enough testosterone to complete puberty. We know that some of our young may have azoospermia or oligospermia. And these are things that we monitor. We check sex hormones. We also are very, very open to referring people to speak with our endocrinologists, our adolescent medicine specialists, our gynecologists, and our fertility preservation program over at Northwestern Medicine. Additionally, I know many people have been talking about fertility issues for cancer patients and survivors, which is very, very important to us. We also know that pre-treatment intervention is the key to preserve fertility in our patients who are going to get gonatotoxic chemotherapy. And we strive very hard when we know patients are going to receive fertility impairing chemo to do fertility preservation prior to the onset of their chemotherapy, which is great for patients we're taking care of now. There is a population that was treated prior to our fertility preservation success, and therefore we need to think on the back end about what do we do for them now. But to preserve fertility, we can do cryopreservation of gametes, and that can happen in several different ways. We can do sperm preservation, so we can have, if young men are pubertal and can produce a specimen, we can cryopreserve sperm. We can do testicular tissue preservation, which is a procedure that happens in the operating room, where a little bit of a testicle is removed and then frozen for future use. We can also do oocyte preservation or oocyte harvesting, and we can do ovarian tissue preservation when a young woman's ovary is taken out of the body and preserved, frozen for future use. So those are all really exciting things that we do, but those are generally done before chemotherapy is started, or at the very latest after a cycle or two of chemotherapy. We treat hormonal late effects by monitoring hormonal levels and then doing hormonal replacement for both men and women. And we appreciate the input of our colleagues in endocrinology, adolescent medicine, and urology to help with this. So let's talk a minute about psychosocial late effects. So you can imagine there are psychological effects that many people experience feelings of depression and helplessness when they're diagnosed with cancer. That there may be school effects, especially as many of our patients spend some time in the hospital during their therapy, and so miss the opportunity to attend school all the time, and either miss the socialization of school or may actually miss some of the schoolwork as well. Interaction with peers, I always think about folks in high school and how important peer interaction is, and looking like your peers and being the same as your peers. And we take that away from people when we give them chemotherapy. And so, you know, there's a period of readjustment. I've had some of our teen patients tell me that I really learned who my friends were during my cancer treatment, and then that changed their social situation. Some people become a little bit less mature, so that their maturity is delayed because they've spent a period of time being dependent on their parents when maybe they wouldn't have been. And so their ability to mature and, you know, separate and individuate as teenagers are supposed to do is a little bit delayed. We know that cancer is really hard for a family, and so families go through it in lots of different ways, and it really affects the way in which family members interact with each other. We certainly have families who really band together and work very closely to make sure that they exit the treatment as a unit. And we also see some families break up in the middle of therapy because of the intensity of it and the intense emotions. And employment, again, there are times when people's jobs that they were planning to do or were doing need to be changed because of a long-term side effect. I take care of a young woman who I met when she was in high school, and because of her diagnosis, she wanted to go to nursing school, and she had had an osteosarcoma, which is a bone tumor of the leg. She had a limb salvage procedure, meaning that she had a knee replacement put in with some hardware that was part of her femur and part of her tibia, and made it through nursing school and got a job as a nurse. And unfortunately, because of some problems with her hardware, had to have some time off of work and some revision of her surgery, and ultimately found that she couldn't do a 12-hour shift at the bedside, and so really has to rethink how she's going to be able to be a nurse given the long-term side effects of her treatment, the surgical long-term side effects. And insurance, at least for right now, you know, pre-existing conditions is not a concern for our survivors. I feel skeptical, and like I never know whether that might be a thing in the long term, whether, you know, if you have anthracycline-induced cardiotoxicity or changes to your heart function based on one of the categories of medication that we give, will that be covered by insurance or will it not? And I think the election next year may give us interesting information. Unfortunately, we have to talk about secondary malignancies. And one of the hardest things I find in telling patients at the time of diagnosis about their chemotherapy or radiation is that there is a possibility that this treatment could cause you to have another cancer. We know that the types of secondary malignancies that we see leukemias and lymphomas in some of our patients. We can see bone and soft tissue tumors. We can see thyroid carcinomas particularly, and we see brain tumors as well as skin cancers. And throughout survivorship, we talk a lot about screening for these things and talk with families about what to look out for. And we do screening ourselves to make sure that these things aren't happening, or if they are happening, that we know about them with enough time to be able to do something. We also have to screen young women for breast cancer. Any young woman who gets radiation to her chest area is at a much higher risk of breast cancer than the general population. So what are these long-term follow-up guidelines that I talked about earlier? Well, they've been created within the Children's Oncology Group. And the Children's Oncology Group is an international group of pediatric oncologists that has really worked to improve the outcome and minimize the toxicity of childhood cancer treatment. And we work as a group to create protocols for kids to be treated on and to collect the data so that we're always trying to improve efficacy and decrease toxicity. And we've been fairly successful in many diseases about doing that, which is super exciting. So as survivorship became more common, the Children's Oncology Group decided that they should also make suggestions for how you monitor long-term survivors of pediatric cancer. And these long-term follow-up guidelines are all based on a child's particular treatment exposure. So every time we think about long-term follow-up, we make it patient-specific, and because those are the things that will affect whether or not they have different types of side effects. These are all evidence-based screenings for long-term side effects of therapy and are really reevaluated on a yearly basis by the members of the long-term follow-up guidelines committee of the Children's Oncology Group. So we're constantly looking at the literature and looking at the data to make sure that we are doing the appropriate thing for our patients. And these long-term follow-up guidelines are helpful in that they generate recommended testing for appropriate surveillance every year or every 2 years or every 5 years, based on the data that we have. And we're lucky to have data for decades about survivors of pediatric cancer. So what are the recommendations? Annual follow-up in specialized late effects or survivorships clinic that follow the COG guidelines is really one of the overarching recommendations from the Children's Oncology Group, because although it's more like general pediatrics than it is like actual oncology care, it has a twist. As we look at the amalgamation of somebody's treatment, we think about their organ systems differently from somebody who hasn't been affected by cancer treatment. We also are hoping that our other specialties recognize the needs of this unique population, because we certainly can't take care of them in a vacuum. We know that we need endocrinologists, cardiologists, nephrologists, our neurocognitive specialists, and primary care providers, because it takes a village to take care of a survivor of pediatric cancer. And so my hope that at the end of this is that folks in the audience are getting information that they can use, and also that you know that you can use me as a resource if you have questions about patients that you take care of. And I'm more than happy, even after the questions are over, to share contact information for the future, because it's really important that our patients have a village taking care of them, because they see us but once a year, and they need to be seen by everybody, and everybody needs to understand at least a little bit about how they're different. We also provide our patients with a survivorship care plan and treatment summary. So if you're seeing a young person who's had cancer and you want more information and we somehow have not sent you a letter, you can ask the family to provide that to you. Or you can, if you're a member of the Children's Integrated Network and can see our EPIC, you can see the abstract in their chart. So I was just looking, this is getting pretty late. I'm going to talk really fast like the New Yorker that I am. So our long-term clinic is called STAR. It stands for Survivors Taking Action and Responsibility. It is our late effects program here at Lurie Children's. It is comprehensive and multidisciplinary. We follow general oncology patients, we follow patients post-stem cell transplant, and we follow our brain tumor population. To go to this clinic, you need to be greater than 5 years from a diagnosis of cancer or greater than 2 years from a transplant of hematopoietic stem cells, like Dr. Chowdhury was talking about this morning. And we take care of patients who are treated at Lurie and patients who are treated elsewhere. We can follow patients in our clinic until 25 or 26 years of age, and at 25 or 26, we have a beautiful, relatively seamless transition to the STAR program for adult survivors of pediatric cancer at Northwestern. We really need all of your help to make sure that our survivors of pediatric cancer are receiving excellent care, and we appreciate the time and attention that you put into this talk today. And now, Chad, if there are questions, I'd love to open the floor.
Yeah, there are some questions coming in. And as we get to those, first of all, thank you. This is such an important topic that we really needed to get out there, because the engagement that we have with our community pediatricians is extremely important, right? I mean, they are our gateway to the patient, right? They see their patients more than we do in some cases. So the communication is so important. So I just thank you again for being here for that. So what question comes in? What types of providers are on your STAR team to support patients? Can referrals be made directly to these therapists?
That's a great question. So our core team for our STAR program is Liam Coakley, who is a registered nurse, Karina Danner-Koptic, and Rachel Cheng, who are advanced practice nurses, and myself, and clearly I'm a physician. We also have input from our brain tumor physicians on a rotating basis. We use Dr. Stephanie Powell, who is one of our neuropsychologists, and she just hired a new partner whose name I unfortunately don't know. We have the pleasure of having Dr. Jenna Shapiro and Dr. Edna Romero, both of whom are psychologists that we refer our patients to. We unfortunately do not currently have a social worker associated with the survivorship program itself, but we make use of our oncology, stem cell transplant, and brain tumor social workers for help. And we also have our adolescent and young adult patient navigator, Jennifer Carrera, who will help meet the needs of patients who are diagnosed at the age of 15 or above.
So with our survivorship programs, obviously we have downtown. Are they in the suburbs? Do we have? So where do we have the programs in the suburbs?
That's a great question. So currently, one day a month, we go out to Northwest Community Hospital. As our affiliation with Northwest Community Hospital is changing, we are looking for a new home for our outpatient. We're looking to be in the Northwest suburbs somewhere so that our patients don't have to come all the way downtown every year.
Right. So they can't come to our outpatient center though in Arlington Heights, right? Not in the Northwest Community Hospital per se, but is it in the outpatient center?
Yep.
Yeah.
Yep.
Okay. So that's excellent. Thank you. Yeah, I know that's on top of mind for a lot of people, and we will be sharing more information as that comes along. How about telemedicine support? For this, is that available?
Yes, we actually during COVID made one day a month a telemedicine day, and interestingly enough, people didn't really like it. I
can imagine.
Something really comforting about coming back to the place where you were treated and seeing people in person. The other problem with our telemedicine visits is that we can do a telemedicine visit, but there is ancillary testing that needs to be coordinated, and those are things that we cannot do remotely. So it still necessitates a visit either to one of our outpatient centers or downtown to the main hospital.
So we have a great multidisciplinary approach to this, which is absolutely wonderful. And the patient's getting all this great care. How about the parents? The parents, they go through a lot with this, right? I mean, probably as much as any other treatment that we have here at Lurie Children's. Do we have anything for the parents? Or is it just one-on-one consult with the docs or with maybe a behavioral health specialist?
That's a great question. We do a couple of different things. We do have parent-wise volunteers that we can connect parents with. And parent-wise volunteers are folks who've had a child with cancer and sort of made it to the other end and are doing fine. They're not struggling anymore. we make referrals to community partners that do support groups for parents of children with cancer. And we also have a caregiver support group through the AYA program for people whose kids were diagnosed at 15 or older. So we do in-house, we do within the Lurie Children's Northwestern community, and then we do really out in the community referrals for people.
That's awesome. You know, you brought up ParentWise. I think I remember, did I see a program called TeenWise or something like that? Is that part of it too?
That is for the patients themselves to find sort of a peer mentor who's been through what they've been through.
Okay. For all that information, whether it's ParentWise, TeenWise, the STAR program, or any of our other programs, you can find them right on our website. And for you pediatricians out there who are either watching this live or will be watching the recording, you have questions about any of this, please reach out to your liaison, myself, who takes care of the north suburbs and the city north, Paula Nowak, who is in the city and southwest suburbs, and Julie Kalkbrenner, who handles the west and northwest as well. So with that, I don't see any more questions. Dr. Reichek, you were absolutely wonderful and outstanding, and thank you for joining us today.
Thank you so much for the opportunity.
You're welcome. And I'd like to thank the audience for joining us today. Please join us next week for session 5 of our roundtable, as we will introduce you to Dr. Joanna Weinstein. She will be discussing cancer predisposition, what families and PCPs need to know. But with that, thank you again for joining us and have a wonderful day.